Good morning, welcome to another NIPMed tutorials. Today we'll be talking about cervical cancer. It's the second commonest malignancy after cervical cancer of the breast. It's the most common genital malignancy. Peak incidence is usually at 45 to 55 years, and the most common type is squamous. Then less common is adenocarcinoma, and then the least common is adenosquamous. So the spread begins with local infiltration, lymphatic spread, and then hematogenous spread, which is rare. So certain risk factors, which is not listed here, but I want you to pay attention for cervical cancer. One of them is presence of HPV infection. Second is immunosuppressive states such as HIV. Third is multiple sexual partners, especially having multiple unprotected sexual intercourse, and history of things such as smoking. Remember, any squamous cell carcinoma, whether lungs or esophagus or cervix or any form of squamous carcinoma, smoking is a risk factor because the oxidative stress produced by smoking, it's only the squamous epithelium that can withstand it. So most other epitheliums, usually the columina, will have to undergo metaplasia to squamous in order to withstand the stress. Okay, so squamous cancers are usually associated with smoking. So risk factors for cervical cancer, we have exposure to HPV, which can occur due to multiple sexual partners and unprotected sexual intercourse. Second is what any immunosuppressive states such as HIV, because we know that CD8 cells are natural killer cells helping fighting cancerous cells. So when the immune system is down, especially HIV infection, the malignancy can propagate. Third, like we said, smoking. Okay, smoking is another risk factor for cervical cancer. So remember, the HPV virus is the culprit, is the cause of it. We have HPV 16 and HPV 18. Now HPV 16 works via certain pathways, and what it does is that HPV 16 produces an oncoprotein called E6, which inactivates TP53. What happens is that E6 inactivates P53, and we know P53 is a tumor suppression gene that's supposed to stimulate apoptosis in the presence of DNA damage that cannot be repaired. Okay, so P53, when it's inhibited, there's apoptosis is inhibited, so the damaged DNA will be replicated, producing neoplastic cells. Okay, while HPV 18 produces E7, which then inhibits retinoblastoma protein. When retinoblastoma protein is inhibited, there will be an increased activity of E2F, which is a family of transcription factors. So there will be cellular proliferation and so on and so forth. Okay. So now, clinical features, usually asymptomatic. They complain of vaginal bleeding, will be intermenstrual, postcoital, or even postmenopausal. There's always offensive vaginal discharge. You might be praying from nerve involvement on the pelvic side. Then leg presentation, backache, especially in the setting of metastasis, leg pain and edema and setting of obstruction of the ureter leading to some form of renal impairment, and then hematuria. Management, go to the full blood count, serum ENU, intravenous urogram, chest x-ray, and examination under anesthesia. When you're staging. And then the mitral biopsy, cervical biopsy, cytoscopy. So staging, there are four major stages. Carcinoma strictly confined to the cervix. Carcinoma extends beyond the cervix but has not extended onto the pelvic wall. Carcinoma involves the vagina but not as far as the lower third. First stage is carcinoma has extended onto the pelvic wall. On rectal examination, there is no cancer-free space between the tumor and the pelvic wall. The tumor involves the lower third of the vagina. All cases with hydronephrosis or non-functioning kidney should be included unless they are known to be due to another cause. So you can see that the affection of the pelvis also extending to the ureter causing hydronephrosis. Then fourth, carcinoma has extended beyond the true pelvis or has clinically involved the mucosa of the bladder or the rectum. That is the final stage. So treatment is either radiotherapy, surgery, or combination of surgery and radiotherapy. Now, like also most surgery depends on the stage. So radiotherapy is indicated in all stages. We have brachytherapy, therapy, and combination. So what happens in the intra-cavitary irradiation? The uterine or vaginal applicators are inserted in the theater. The position is confirmed by what? An X-ray. Okay, and the uterine and vaginal sources are subsequently inserted. That's what they call the afterload application. That's the source of the radiation also inserted. What happens is 7,000 to 8,000 rad is delivered to point A. Point A bar is arbitrary point 2 cm lateral to the center of the uterine canal. Okay, 2 cm up from the vaginal skin of the lateral fornix in the plane of the uterus. That's point A. If you actually go to Google and look for some images, it's actually clearer to understand there. So 2 cm lateral to the center of the uterine canal and 2 cm up from the vaginal skin to the lateral fornix. That's where the beam is delivered to. Now I have intra-cavitary irradiation using case 137. This is another important. So external irradiation, especially when the pelvic wall has been involved and when there's a large lymph node. Now complications of radiation could early or late. Early is proctitis, cystitis, and dermatitis. Late one is stenosis of the rectum, intestinal obstruction, rectovaginal fistula, and also VVF. So surgery is indicated in stage 1A, stage 1B, and stage 2A. And the advantage of surgery is that it can help to preserve the ovaries. Okay. Now, what they call the procedure called West-Ham hysterectomy, which is the total abdominal approach. Then Shauster's hysterectomy is vaginal approach. So the advantages of surgery that treatment is less prolonged. You can preserve the ovaries in younger women. If they have an infection, is not a contraindication for after the surgery. And also, it can assist radio resistance, so it prevents radio resistance from occurring as tumors that are resistant to radiotherapy because you're excising the masses, excising them. So the likelihood of them being resistant to radiotherapy is low. Disadvantage is that selected patients benefit, so it has to be stage 1A, 1B, and 2A. Patients that are beyond that level will benefit more. It's more hazardous than radiotherapy because of the extensive dissection and the risk of even tumor spreading hematogenously. Bladder dysfunction is common, and then the vagina is usually shortened. Another type of surgery is pelvic extenuation. Usually is indicated in case of advanced cancer and ensure relatively comfortable life. So the anterior ones come from the anterior aspect, removing the bladder, doing radical hysterectomy and lymphadenopathy. Posterior one are coming from behind, and behind the uterus is the rectum. So remove the rectum and then do the same procedure. In total, when we clear both the bladder, rectum, and the uterus. So complications of surgery. We always have most all surgeries have three major complications: complications of the anesthetic agents, hemorrhage, and infection. So early one is anesthetic. Hemorrhage can lead to shock, infection causing sepsis, and thromboembolism from lying down and immobility. That's from stasis of blood. Then late is a ureteric rectal fistula, a cyst, and then urinary retention. So survival rate depends on stages like all cancer. Stage 1 having a higher survival rate, and stage 4, which is distant metastasis, having a lower survival rate. Terminal care, usually in stage 4 cases. Psychological support, when we put focus on family, religious leaders, trained social workers, hospice care, and then pain relief. Narcotics for visceral pain, antiprostaglandins for bone pain, corticosteroids for perineal edema, nerve block, intrathecal injections, that's injection into the spine, cordotomy, and palliative radiotherapy to relieve symptoms. Prevention of cervical cancer, public enlightenment, sexuality education, family planning using barrier method, National Cervical Cytological Program, and training of personnel. Under this National Cervical Cytological Program, we are trying to push people into having an early pap smear. Pap smear usually is indicated about 3 years after the commencement of coital care. That's the first time patient has sexual intercourse, and it's usually advisable. There's also an HPV vaccine available which could also prevent development of cervical cancer since HPV is a positive agent. Thank you very much.